I think it's really important to recognize that, you know, although this is maybe an advancement in the field, it's not maybe where we want to be ultimately, right? And immunotherapy offers some exciting results in terms of duration of effect and maybe some complete responses in some patients. What are the adjuvant therapies that we're doing right now? Bob, Brad, can you comment a little bit on the current adjuvant studies that are going on, sort of industry studies? And Nick, I'll ask you to talk about the neoadjuvant study. Yeah. That's a kind of cooperative group-led study.
Yes, I mean, I think when you look at the purely adjuvant studies, there's 2 trials ongoing that have a very similar design. One trial is looking at pembrolizumab versus placebo, the other one looking at atezolizumab. Both trials are looking at those with high-risk disease, so T2, grade 4, T3, T4, and I know the pembrolizumab trial has an arm that's sort of this M0 NED, so M1 NED, so if you've had surgery for metastaectomy within a year of the nephrectomy, you also go, so those patients obviously have very high risk for distant recurrence, and so comparing sort of immunotherapy with either agent versus the placebo.
Right. Good. So there's a couple of immunotherapy options, single agent kind of checkpoint strategies. What about the neoadjuvant? How is that different, Nick?
Well, Lauren Harshman's got a nice trial. It took a lot of time getting through the GU steering committee, and there was a lot of controversy, but basically it's neoadjuvant. You biopsy the tumor, and you don't, by the way, have to have histology. You just have to prove that you've done the biopsy. My first patient got his biopsy, was negative, and I thought couldn't get him on trial. You then give them 2 cycles of nivolumab, nephrectomy, and then they're randomized to either no additional nivolumab or I think a year of nivolumab. It's a little easier because nivolumab is given, I think, every 4 weeks. So it's a bit easier trial. It's not so stark where it's like, well, you're not getting it and you are. Everybody gets a shot at nivolumab in that trial. So I think it's a good trial. I think it'll fly.
Great. Yeah, I think the key thing with studies like this is the sort of multidisciplinary coordination with urology. Can you guys talk a little bit about how that's working in your center and any advice for groups out there on how to set this up? 'Cause I think to this point in time, you know, there hasn't really been necessarily multidisciplinary care with urology in renal cell carcinoma because we just haven't had that many treatment options to share in this setting. Bob, any thoughts on that from Hackensack?
Sure. I think that the first thing is you have to have a good rapport with your Department of Urology. I mean, again, in private practice as well as the faculty practice, you really need to be able to recognize it's about patient care. Mm-hmm. The ability of now having, even as we look at it, adjuvant data, we have to allow our urologist partners to let us know that these patients are out there. We should be seeing these patients who are at risk. Even when you look at the PROTECT clinical trial, which had patients at T2 disease, or even in the ASSURE looked at T1B patients, it just allowed them to recognize that all patients in a higher risk of concern of recurrence should be referred to a medical oncologist just for an assessment. I think the surveillance scans that we do should be done properly based upon NCCN guidelines. And I think the fact is that they will still maintain their care under the urologist as well as the medical oncologist. It gives us the ability to make sure the patients really be monitored and managed appropriately, so laboratories as well as scans. The ability of having neoadjuvant clinical trials definitely includes our urologists because it definitely allows us to be offering them an option of therapy while they're still going for their cytoreductive nephrectomies or nephrectomies in the curative intent. I think the allowance of the urologist to let us be partaking in their patients is quite important, and it gives the patients the ability that they're being sort of overseen by 2 multidisciplinaries that really are looking for their overall survival.
Great advice. I mean, I think, you know, coordination of care, recognizing the importance of bringing in, you know, that medical oncologist even before nephrectomy to open up some of these neoadjuvant options, recognizing both the standard of care in immunotherapy clinical trial options, you know, that's out there today. I mean, I think this is an exciting time right now for adjuvant therapy. I don't think we've ever had this kind of diversity of trials and standard options before. And, you know, really look forward to seeing how the community kind of adopts all of this in their practice.